Okay, guys. We, for this supplemental chapter 29 PowerPoint, we are going to pick up where we left off this morning, Monday morning. And now we're going to sort of leave behind acute kidney injury, and we're going to move now into sort of more chronic kidney failure or chronic kidney disease. Okay, so again, we're sort of switching gears now. So I said, over and over again this morning that acute kidney injury is reversible and can be completely treated, and it can be a short-term sort of temporary injury to the nephrons, injury to the kidneys, if those underlying problems are turned around. Now, switching gears to chronic kidney disease, this now, to be clear, represents progressive and irreversible failure of all of the functions of the nephron that we talked about last Thursday. So that is failure of filtration, reabsorption, secretion, and then concentration of those abilities of the nephron. And also looking a little bit at sort of the renal endocrine functions as well that we'll talk about at the end of the semester. So again, to be clear, this now is progressive irreversible destruction of the nephrons in both kidneys. Now, interestingly, the remaining functional nephrons can accommodate up to a point for lost nephrons. And I sort of alluded to this after one of the questions in class this morning. That a person has to lose 70 to 80% of the nephrons before renal failure or chronic kidney disease actually kicks in, before we can actually diagnose and say that someone has chronic kidney disease. So that's a lot. I mean, you've got to lose a lot of kidney function before we actually call it chronic kidney disease. And what you then see in chronic kidney disease is what we call uremia. And really the other sort of way to think about this is literally urine in the blood. I don't necessarily mean that there's urine in the blood, but all of those sort of toxic waste products like urea, blood urea, nitrogen, creatinine, all of those sort of things build up in the blood. So the blood looks like what the urine should look like in terms of its makeup. With chronic kidney disease. And what you can actually see in someone, they have so much of this uremic buildup, if you will, that you can actually see what they call a uremic frost on the skin of patients with chronic kidney disease. And what this basically is that it's these sort of these urea crystals that build up on the skin because there's so many of these toxins in the blood that it actually leaches out and leaks out onto the skin. Very similar to like if you run a long distance and done a lot of sweating over a long period of time, and then you allow that sweat to kind of dry. And if you've ever noticed, like after you go for a long run and then the sweat dries and you sort of have that like crusty, sort of frosty, salty ring on your forehead or on your clothes or something like that. That's kind of what this uremic frost looks like. It's these urea crystals that actually build up on and under the skin. Again, because there's so much of these toxins in the skin or in the blood, and it's extremely itchy. It's very irritating. So you'll see some of these chronic kidney disease patients like just wanting to claw their skin off. It's so itchy. And again, it's because of this uremia. This basically urine, what should be in the urine is now in the blood because of the poor job that the kidneys are doing at filtering. And, I'm sure you know that the etiology of chronic kidney disease can be from a variety of diseases. Number one being diabetes, just because the high glucose content or the frequent swings of the glucose content in the blood is very damaging to the capillaries in and around the nephron and the kidneys. And then number two disease for what causes chronic kidney disease is hypertension. Again, because that high pressure, hypertensive situation in those small capillaries in and around the nephron in the kidney are very damaging. And also to be clear, if you don't turn around the pre-renal reasons for acute kidney injury, or you can't fix the short-term intra-renal reasons for acute kidney injury, you can certainly see those things sort of compound themselves and cause permanent damage, and then which leads to chronic kidney disease as well. So to be clear about that. Okay, but here's a really a sort of an old data, but none of it's really changed. In showing you so it's from 2007, but in showing you ESRD, so end-stage renal disease incident in patients according to their diagnosis. And again, you see here exactly what I just said. Diabetes as being the #1 reason in terms of diagnosis that leads to end-stage renal disease, and then hypertension being the second. Okay. So, in the classification of chronic kidney disease, we kind of mentioned this already, in that you really don't start talking about what they term technically chronic kidney disease until the GFR, the glomerular filtration rate, is around 90. That's when you start to say that this person has sort of stage 1 chronic kidney disease. And again, remember, if you sort of look here at the classification of chronic kidney disease, it really is all based on their GFR, on their glomerular filtration rate. So you can see with each stage, what their GFR sort of looks like. And it's, again, normal being 125. So you can see that there's you really don't even really get concerned really until you start to see it really around 90. For stages 1, 2, 3, and 4, here the goal really is to just slow down the progression of the loss of GFR before you even ever get to stage 5. So it is possible to sort of slow down the progression of the loss of GFR and never even get to sort of stage 5, which is true kidney failure, which was where we're talking about here. It is that someone would need dialysis or transplantation. So that being said, what do you think you can sort of do in terms of this goal to slow down progression from stage 1 through 4? It would be things like, collaborative care of whatever disease is causing that loss of GFR in the first place. So obviously if that's diabetes, it's diabetes care compliance with getting those sugars under control. If it is hypertension, it's blood pressure control and, be it through medications, diet, lifestyle, whatever it may be. So again, it's 5 here that we're talking about end-stage renal failure, where someone would actually need dialysis or transplantation. It's here, 1 through 4, that you really can see, some interventions, be it pharmacological or other lifestyle things, that can actually slow down, if not stop, the progression through these stages. So again, this kind of says exactly that. So the focus in chronic kidney disease is on prevention and early detection to basically deter the progression of kidney disease through those stages on that previous slide. Adverse outcomes can oftentimes be prevented or at least be slowed down through early detection and treatment of any sort of major diseases that would sort of lead to chronic kidney disease, again, like diabetes and hypertension. So again, I've kind of said this already, but goals of chronic kidney disease treatment: preserve existing kidney function of whatever is left, treat any underlying cardiovascular disease that could be damaging those nephrons and those capillaries in the nephrons, prevent complications, and obviously provide for the patient's comfort. Again, the focus in stages 1 through 4 includes control of hypertension or any other types of diseases that would be damaging to those nephrons, like hyperparathyroid disease, anemia, hyperglycemia, high cholesterol, hyperlipidemia, things like that. Okay. And that says that exactly. I have a lot of slides on that for some reason. I apologize. Okay, so for the rest of the time regarding chronic kidney disease, instead of just monotonously kind of listing off every single sort of clinical manifestation that a patient can have with chronic kidney disease, what I've sort of done for the rest of this lecture is to discuss some of these clinical manifestations and some of these problems that you see in patients with chronic kidney disease through the lens of case studies. So we'll be talking about a lot of different clinical manifestations, but we'll be talking about them through the lens of several of these case studies. And again, this is what I want you to sort of listen to and sort of review with these with this voiceover, and then when we get back together next Monday on the 18th, we will spend some time talking through these case studies together and sort of coming up with our each individual understanding of all of these clinical manifestations of chronic kidney disease in preparation for the exam. Okay, so first case study, chronic kidney disease. We have Mr. Howard Jones. He's a 58-year-old male who's admitted to KU with a 2-week history of nocturia, hesitancy, and dribbling and straining with urination. For the past 2 weeks, he's also been complaining of malaise, anorexia, and nausea. He's recently developed swollen legs and puffy eyelids, so he's got some edema going on. You see his admission lab values there, and you see his 24-hour urine collection has only yielded 300 cc's. Mr. Jones' vital signs are blood pressure, you see there, heart rate, and respiratory rate is 26 and deep. So the question for this case study is the following. What findings, either laboratory or physical findings, reflect fluid, electrolyte, and acid-base imbalances for Mr. Jones? Okay, so the first thing that you see here in terms of fluid imbalance would be clearly now his swollen legs and puffy eyelids. So he's got some edema going on. He's got fluid volume overload here. So that's sort of the physical finding that shows you that he's got fluid volume overload. Now, in terms of electrolyte imbalances, we have a frighteningly high potassium here of 6. So that shows you right there that potassium is elevated. And then you'll also see in terms of his acid-base imbalance, you see that his pH is 7.3. So he's quite acidotic. And you also see that his bicarb is low at 20. Remember, normal bicarb is levels in the serum should be about 22 to 26. So right here, this shows you that his bicarb is low, which is going to predispose him to being metabolically acidotic, which you see right here with his pH of being 7.3. So this case study right here, oh, and you see that his BUN and his creatinine are also quite elevated. So this case study right here illustrates the fluid imbalances, the electrolyte imbalances, and the acid-base imbalances that are very, very true, very common clinical manifestations of someone with chronic kidney disease. And to be clear, again, when we're talking about sort of stages, the previous stages of chronic kidney disease that we just discussed a couple slides ago, all of the sort of management strategies for all of these abnormalities that we're going to find in this case study, series of case studies throughout this lecture, are going to be some of those collaborative care sort of management strategies that would certainly be implemented in that stage 1 through 4 to kind of address those problems before it gets so bad that they get to stage 5. Again, so a lot of these clinical manifestations that we're going to be talking about through the use of these case studies are indeed what I was talking about in terms of management strategies of levels, stages 1 through 4 of chronic kidney disease. Okay, so we have now elicited what these imbalances are for fluid, electrolyte, and acid base. Now, what strategies are available to manage these imbalances? Well, let's talk about each one of them specifically. Okay, so the first thing we're going to talk about that was just illustrated in this case study was metabolic acidosis. So again, there's a definition of metabolic acidosis for you. I don't think I necessarily need to read that to you. But you see here, right, that in chronic kidney disease, metabolic acidosis occurs when bicarb is lost from the body via the kidneys, when the kidneys fail to regenerate bicarbonate through adequate acid secretion. So really, it's this loss of bicarb due to the inability to reabsorb bicarb back into the blood, back into the capillaries. So, what do you think the fix for this is? How do we treat this major sort of clinical manifestation of chronic kidney disease? You're missing bicarb, you give bicarb. So this is treated by giving these alkaline medications, bicarbonate right here. The other thing you'd obviously want to do is continue to monitor their ABGs because again, an arterial blood gas is going to continue to tell you the serum pH of these patients, and of course it'll also tell you the serum bicarb. So you're monitoring each one of these things very closely through the ABGs. You will also give alkaline medications like IV bicarb that will fix that lack of bicarb. The other thing I wrote here on the screen is that you will want to avoid a catabolic state. What I really mean by a catabolic state is just kind of avoiding any sort of hypermetabolic state. So a catabolic state or a hypermetabolic state is when the body tissues and components are sort of breaking down into simpler sort of metabolic constituents. And oftentimes this can be caused by prolonged bodily stress, like illness, like fever, things like that. So patients with renal failure and critical illness in general are characterized by highly catabolic states. So metabolic acidosis certainly will contribute to this. So it's kind of this double-edged sword, right? Metabolic acidosis kind of is a hypermetabolic state, but also these patients are probably sick. These chronic kidney disease patients are probably sick anyway. And so you have this really sort of hypermetabolic state that can then worsen this metabolic acidosis. So keeping that in mind is also something to think about. Okay, so there we go. Metabolic acidosis explained there for you. Also, as we move through each one of these sort of clinical presentations or clinical manifestations of chronic kidney disease, these are in no order. So it's not like these are presented to you in some sort of prioritized order that you would need to know for the exam. I'm just simply talking to you about all the clinical manifestations that you would see in chronic kidney disease through the lens of a case study, and then talk about the pathophysiology of that and any management strategies for that. So again, to be clear. All right. All right, the other imbalance that we talked about from that previous case study with Mr. Jones is a fluid balance alteration. Now, again, the reason that there's oftentimes you will see a fluid volume overload in these patients with chronic kidney disease is because of the poor filtration of the kidneys. And so you're just not getting rid of all of that fluid, and it's staying behind in the vasculature and overloading the cardiovascular system. So how do we treat that? Why is he retaining this fluid in the first place? Well, answer, the nephrons aren't filtering. So what do we do? Well, obviously then we're going to try to restrict any fluid intake, be it PO or IV, to decrease the fluid on board in the first place. So that being said, we're going to really very closely monitor and do accurate intakes and daily weights and I's and O's and all of that. We also will consider, and we kind of talked about this already today, giving diuretics. Again, this is going to be blocking the water reabsorption in the tubules and getting rid of any fluid possible through those tubules. So again, that's kind of the management of the fluid balance alteration that you see in chronic kidney disease. Again, retaining fluid in the first place because the nephrons aren't filtering that fluid out. Okay, and then the other big imbalance that we saw with Mr. Jones was his potassium. His potassium was 6. Again, frightening to myself as an ER nurse if I see, again, remember I told you, a potassium of anywhere sort of not near the number 4, that's concerning. And again, serious complications come from hyperkalemia that certainly require emergency intervention. So if you would see that high of a level of a potassium, again, because it's not being adequately secreted out of the blood into the tubules and then sort of eliminated through urine, so oftentimes what you're going to see is, first of all, the lab is going to want to redraw. They're going to say, that can't be possible. The K cannot be that high. Let's make sure that that's an accurate result. So you're going to always verify the lab results. Again, if you see a K of 6, you're going to sort of run and get that EKG machine and assess for any sort of life-threatening dysrhythmias. Again, remember we talked about this when we talked about electrolyte imbalances last semester, but the major sort of EKG finding with a hyperkalemic state is what we would call a peaked T wave, which is what you see right here. Again, remember the normal T wave should be sort of low and sort of rounded right here. And you see here, not only is the T wave peaked, but it's also almost as high in terms of amplitude as the QRS wave. The QRS complex, I should say. So again, it's these tall, tented, peaked T waves that you'll see quite often on an EKG when hyperkalemia is present. So that's what you're going to see on the EKG machine. Obviously, in terms of management of this high K because of lack of secretion out of the kidneys, you're going to do education about avoiding potassium-containing medications. You're going to be avoiding potassium in their diet, so you'll be doing some dietary counseling of trying to keep that daily intake of K to about 2 to 3 grams daily. Obviously, be very careful about any potassium that might be in their IV fluids that they're receiving. And I can guarantee you that if I have a patient come in with a potassium of 6, as Mr. Howard's is here, that I will not just sit down at the bedside and talk to them about avoiding potassium medications or doing some dietary counseling. No, quite the opposite. I am going to be getting some emergent medications to decrease this level of potassium now. Preferably yesterday, right? So let's talk a little bit about some medication, some pharmacological management for a hyperkalemia. Okay, so this screen is extremely busy, and I can honestly tell you that in the real world, every single one of these medications you would, as a nurse with someone with a high K, and you would be anticipating to give. But the two that I really want you to focus on and know for the purposes of this class and for the exam is K-exolate and insulin and dextrose. So again, let's talk a little bit about these. Now again, this is by no means a pharmacology class, but again, I want you to sort of see and want to illustrate, as always, what a tight sort of collaboration and integration there is between pharmacology and, pathophysiology. So I want to very briefly here talk about the importance of K-exolate and insulin and dextrose in the treatment of a high potassium. Okay, so first of all, the major medication here that will help take down that high K level is something called K-exolate. This agent promotes exchange of potassium for sodium in the GI system. So what essentially happens is it pulls that excess potassium in the blood, in the serum, from the serum into the GI system. And then, as you know, as we have talked so much already throughout the year, because of that ion transport sort of pump, wherever potassium goes, sodium goes in the opposite direction. So it literally does exchange potassium for sodium in the GI system. So potassium goes into the GI system and sodium gets pumped out of the GI system into the serum, into the blood. Now, this works fantastically. K-exolate works great because once you've done that ion exchange in the gut, then you have diarrhea. I mean, you literally just then excrete this excess potassium out through stool. However, look here at the onset. The onset of action after you give this to someone, PO, so they drink this. It's like this really thick, sort of syrupy, caramely looking resin that they actually drink by mouth. The action of this exchange of potassium for sodium in the GI system, thus pretty effectively dropping the potassium down, ranges from about 2 to 12 hours. So it starts to lower potassium over 1 to 2 hours with a duration of action of about 4 to 6 hours. The problem is, again, as you see here, that it can take several hours to drop that serum potassium level by drawing that potassium into the GI system. So I don't know about you, but I don't feel really comfortable sitting around with someone with a potassium of 6 to 7 just waiting for a few hours while this K-exolate starts to work and drops that K. So, to be clear, the K-exolate is the longer acting, sort of long-term fix for getting a serum potassium level down. But in the short term, we've got to do something to make that happen faster. I am not comfortable with sitting there waiting for K-exolate to work for several hours with a K of 6. So, what the short-term treatment for a hyperkalemic state is giving IV insulin. About, as you see here on the screen, 5 to 10 units of regular IV insulin. What this does is that the insulin temporarily shifts the potassium out of the blood into the cells. And it can work very quickly. This works, the onset for this treatment of getting serum potassium down is quick. It's like 30 minutes. Now, Again, it's about 5 to 10 units of regular insulin IV. So you're doing that while you're sort of waiting for the Kxalate to kick in. Now, why might 1 to 2 amps of dextrose, glucose, be given at the same exact time that insulin is given? Think about it. It's basically just to counteract any hypoglycemic conditions that giving someone 5 to 10 units of insulin may create. Again, glucose does nothing to drop the K serum level. It literally is just there to counteract the insulin from preventing, some sort of hypoglycemic state when trying to treat this K with insulin. Hope that makes sense to you. And again, we can talk about it more on Monday if we want to when we're talking about these case studies. But again, want you to understand both the long-term Kxalate and the short-term insulin and dextrose treatments for emergently bringing down a potassium level. And just kind of so you know, this insulin and dextrose may last about an hour or so, so it's kind of a quick fix to very quickly get that K down while you're waiting for Kxalate to work more long-term. Okay. And then we talked a little bit with Mr. Howard, I believe his last name was. We talked a little bit about him also having hypertension. So if you look back at that case study with Mr. Howard, his blood pressure was elevated. His blood pressure is 160/90. You'll also see hypertension with these patients with chronic kidney disease. And again, it should hopefully make sense to you because of that fluid overload that we've already talked about, because of the excess fluid on board, because it's not getting filtered out of the kidneys. But you see here in terms of management of these cardiovascular sort of hypertension problems of chronic kidney disease, is that hypertension, as we said already, is both a cause of chronic kidney disease and then also an effect. So that there's sort of that sort of complicating factor about that. Again, evidence suggests that adequate blood pressure control can really slow down progression of stages 1 through 4 of that chronic kidney disease. So you have to address any modifiable risk factors at all, if possible. We already talked about how the use of diuretics can also help with getting excess fluid off and for the treatment of edema. And then other antihypertensives may also certainly be needed and certainly be used in terms of the management and of the fluid volume overload, which then leads to hypertension in these chronic kidney disease. Interestingly, chronic kidney disease patients have an increased incidence of cardiovascular complications. So really what's interesting is that many patients will die of cardiovascular disease before they ever really truly reach the need for dialysis. So again, these two compounding factors of cardiovascular disease, both as sort of a cause and an effect of chronic kidney disease, is certainly very present in these patients. And again, that's how we would manage it, both with diuretics, with lifestyle modification, and then, of course, other antihypertensive medications as well. Okay, so through that case study of Mr. Howard, we have discussed the issues of fluid imbalance, electrolyte imbalance, and acid-base imbalance, again, through both his physical and his lab findings. And again, we will talk more about that as a group and answer questions as we get together again on Monday. So those were several of the sort of clinical manifestations of chronic kidney disease. Now let's take a look at some other manifestations of chronic kidney disease through a new case study. So here we have Andrea Zeppa. She is a 67-year-old female who's been told by her nephrologist that she should start considering dialysis. So again, she's probably teetering between that sort of stage 4 and stage 5 of chronic kidney disease. So she's getting to that stage 5 where really nothing else can be done other than putting this patient on dialysis. This stage 5 kidney disease resulted from a history for her of hypertension, which is currently controlled by antihypertensives, but she had a lot of hypertension leading up to that. She also has some mild rheumatoid arthritis. Her pertinent lab values at presentation include a hemoglobin of 9.4. The patient complains of generalized weakness and shortness of breath on exertion, and she tells the clinicians that she dreads climbing the stairs because it, quote-unquote, drains all of my strength. So from this case, from this presentation, what are the symptoms associated with anemia in this patient? Again, her symptoms would obviously be her shortness of breath and her complaint of generalized weakness. She this concept that she says that she dreads climbing the stairs because it drains all of her strength. That probably is due to the lack of oxygen carrying in her blood, as we talked about already in the hematologic content. So those are some of the symptoms. And then you can see, objectively speaking, her hemoglobin is low. It's 9.4, right? Remember, normal should be about, 12 to 16. And we're starting to get, it's pretty worrisome when you start to see 6 to 9, right? Especially for renal failure patients. So again, with the combination of the presentation of her hemoglobin and her complaint of weakness and shortness of breath, these are sort of the symptoms associated with anemia in patients with chronic kidney disease. And again, I talked about it already earlier today, but what is the leading cause of anemia in patients with chronic kidney disease? It's impaired erythropoietin production, right? And we talked about why when we talked about hormonal relationship with the nephron function earlier today. Okay, so what can be done? What can be done to correct this anemia in this patient with chronic kidney disease? So let's talk a little bit about that. So again, I'm not going to spend a lot of time here talking about, red blood cell synthesis, occurring because of the release of renal erythropoietin hormone. We've talked about that already, that relationship between the production of erythropoietin in response to hypoxemia. And this erythropoietin, from the kidneys is what stimulates bone marrow to actually increase red blood cell production. So we've talked about that already. We're not going to spend a lot more time pathophysiologically talking about red blood cell production. So what we do need to talk about is talking about management of how we fix this problem of impairment of erythropoietin. So what does this actually look like clinically? Well, there's actually some sort of synthetic erythropoietin that can be given to help stimulate red blood cell production in these chronic kidney disease patients. And that is through human recombinant erythropoietin. So like Epogen, Procrit, you might be sort of familiar with some of these. And again, they are sort of synthetic erythropoietin. Oftentimes these are given sort of 3 times a week. They're often given sub-Q, so they're sub-Q injections. And again, it stimulates bone marrow to produce red blood cells since the kidneys aren't. Since the kidneys are not adequately stimulating bone marrow, this synthetic erythropoietin will. You also can consider doing some iron supplementation and some folic acid supplementation in these patients, and it is not uncommon at all, and I talked about this already, not uncommon at all for these really profoundly anemic chronic kidney disease patients to get blood transfusions. Oftentimes, if they are on dialysis, they'll receive a blood transfusion while they're hooked up and while they're getting dialysis through the dialysis machine. But I've given lots and lots of blood transfusions to chronic kidney disease patients just in the emergency room because they come in with such a profoundly low hemoglobin. So again, major management there for you for anemia as a clinical manifestation in chronic kidney disease patients. Okay. Next case study. Again, looking at some more clinical manifestations through the case study approach. So here we go. Shelby Latchery, 30-year-old married female with a past medical history of being a brittle type 1 diabetic since childhood, which now has resulted in stage 3 kidney disease. She's been told by doctors for many years that she may be unable to conceive a child and/or it may put her health further at risk. However, 1 year ago, she delivered a healthy baby boy. She today presents to her nephrologist on crutches due to a recently fractured right tibia. Okay, so let's talk a little bit about some of the clinical manifestations that show up here in this case study of chronic kidney disease. Okay, so first of all, disorders of calcium and phosphorus metabolism. Okay, so how do these disorders manifest? They manifest in these chronic kidney disease patients in a couple of ways. Renal osteodystrophy, which is literally the thinning and the softening of bones due to the loss of calcium from the bones. And again, this is stimulated by the loss of activation of vitamin D, as I mentioned earlier this morning. And when you see this loss of activation of vitamin D, you see an increased parathyroid activity stimulated by hyperphosphatemia and hypocalcemia. And so then you'll also see a decreased renal reabsorption of calcium. So what you'll actually start to see is with this hypocalcemia is that you'll start to see demineralization of the bones. You'll actually kind of start to see these people being more predisposed to sort of spontaneous kind of pathologic fractures. So that is certainly something that we're concerned about with what we call this renal osteodystrophy. It's, again, a syndrome of skeletal change found in chronic kidney disease patients that is related to alterations in calcium and phosphate metabolism. So again, just kind of, sort of keeping those in mind in terms of something that you may not think necessarily all that commonly about, and that is issues with bone health in someone with chronic kidney disease. So what do? Basically, we are doing things to replace or sort of supplement calcium and doing things to bring down the level of phosphate. So phosphate binders, as you see here, are calcium carbonate, calcium acetate, some other ones. Again, it helps bring down that hyperphosphatemia, and then giving replacement or supplementation of calcium, so through calcitriol replacement. And you see some of the brand names of some of the calcium replacements that they may use in these disorders of calcium and phosphorus. All right, and then also you can see some disorders of the reproductive system, which you sort of heard mention of in this latest case study. Interestingly, men and women with chronic kidney disease can experience infertility and decreased libido. Women may usually have a decreased level of estrogen or progesterone and luteinizing hormone, which can certainly cause a lack of ovulation and a lack of fertility. And men with chronic kidney disease may experience loss of testicular consistency, decreased testosterone, and low sperm counts. Again, just wanted to sort of mention that because, again, it's not uncommon to see some of these disorders of the reproductive system be present, things like infertility, low libido, things like that, in patients with chronic kidney disease. And again, may not completely be understood, but certainly does show a link between the hormonal sort of relationship and the nephron. So that is there certainly as well. Okay, how do we treat that? What do we do for disorders of the reproductive system? Interestingly, sexual function can actually improve with sort of ongoing sort of maintenance dialysis, and may actually become completely normal after transplantation. Again, so there may not be all that we can do regarding sexual dysfunction in stages 1 through 4, but interestingly, just kind of as a side note, some of this stuff can be improved when someone actually does go on dialysis or they actually have a kidney transplant and they sort of achieve higher functioning renal function again. Okay. Now the rest of this lecture is just information regarding dialysis and how we would actually now treat end-stage renal disease. So again, to be clear, all of the previous clinical manifestations that we have touched on regarding chronic kidney disease, again, through the lens of these case studies, are all the clinical manifestations that you would see in those stages 1 through 4 that would need adequate treatment, that we would need management of these clinical manifestations. Now, once you get to stage 5, treatment of those clinical manifestations like acid-base imbalance, electrolytes, hypertension, anemia, etc., management is not successful anymore. The GFR has gotten so low, it has dropped so considerably that the sort of management of these clinical manifestations is no longer adequate. It's no longer enough. That's when we start to say that this patient, again, in association with their GFR, has reached sort of end-stage renal disease or stage 5 chronic kidney disease. And what we're talking about there is that now this patient is either going to need a renal transplant, they're going to need a kidney transplant, or now they undergo dialysis. And again, what I want you to just understand about dialysis, we're not going to necessarily cover dialysis in patho. But what it basically is that now you are having to synthetically filter out that blood because the kidneys are not doing any of it anymore. So now this is when someone is a dialysis candidate and has to get hooked up to the dialysis machine usually about 3 times a week to actually do all of the filtration and reabsorption and secretion functions that normally our nephrons do. And again, that's what's occurring. That is the treatment for stage 5 chronic kidney disease, end-stage renal disease. Okay. And again, the rest of this dialysis information is going to just sort of be FYI for you in terms of the different ways that we can actually dialyze and treat clinically these end-stage renal disease patients. Okay, and that is it. Okay, so again, I wanted to do a voiceover for you so that we can cover give you some information regarding all this chronic kidney disease. Again, listen to the voiceover. Go through these case studies on your own individually, and then as we get together as a group again on Monday, we'll go through these case studies and talk through a lot of these clinical manifestations together as a group prior to and in preparation for the exam on Thursday. All right, thanks guys.